Question 1. Pain pathways and neuropathic pain. Which of the following best explains the difference between nociceptive and neuropathic pain and how this distinction affects treatment choices? A. Nociceptive pain results from direct tissue damage and responds well to NSAIDs, while neuropathic pain is caused by nerve damage and is best treated with anticonvulsants or antidepressants. B. Nociceptive pain arises from nerve damage and is treated with opioids, whereas neuropathic pain stems from tissue injury and is best managed with muscle relaxants. C. Nociceptive pain is always chronic and requires long-term opioid therapy. Neuropathic pain is short-lived and resolves without treatment. D. Neuropathic pain is primarily inflammatory and corticosteroids are the first-line treatment, while nociceptive pain requires only physical therapy. Answer A. Nociceptive pain results from direct tissue damage and responds well to NSAIDs, while neuropathic pain is caused by nerve damage and is best treated with anticonvulsants or antidepressants. Explanation: nociceptive pain is caused by actual or potential tissue damage, often resulting from injury, surgery, or inflammation. It is usually well managed with non-steroidal anti-inflammatory drugs, NSAIDs, and opioids in severe cases. Neuropathic pain, on the other hand, arises from nerve damage or dysfunction, often seen in conditions like diabetic neuropathy, postherpetic neuralgia, or spinal cord injury. This type of pain does not respond well to NSAIDs or opioids alone. Instead, it is best managed with anticonvulsants, e.g. gabapentin, pregabalin, and antidepressants, e.g. tricyclic antidepressants, serotonin norepinephrine reuptake inhibitors. The CD and American Pain Society guidelines recommend using adjuvant medications for neuropathic pain before resorting to opioids. Question 2. Opioid-induced hyperalgesia, or a patient with chronic back pain has been on long-term opioid therapy but reports worsening pain despite increasing doses. What is the most likely explanation, and how should the clinician proceed? A. The patient has developed opioid-induced hyperalgesia, or a condition where opioids paradoxically increase pain sensitivity, and opioid tapering or switching to non-opioid therapies should be considered. B. The patient has developed tolerance, so the opioid dose should be increased further until pain relief is achieved. C. The patient is exhibiting drug-seeking behavior, and opioids should be immediately discontinued without alternative management strategies. D. The patient's pain is psychological in nature, and opioids should be replaced with sedatives and counseling. Answer A. The patient has developed opioid-induced hyperalgesia, or a condition where opioids paradoxically increase pain sensitivity, and opioid tapering or switching to non-opioid therapies should be considered. Explanation: opioid-induced hyperalgesia, or is a condition in which prolonged opioid use leads to increased pain sensitivity. This is distinct from tolerance, which is the need for higher doses to achieve the same analgesic effect. OI occurs due to opioid-induced neuroplastic changes in the central nervous system, leading to a heightened pain response. The correct approach includes opioid tapering, transitioning to alternative therapies such as NMDA receptor antagonists, e.g. ketamine, or incorporating multimodal pain management strategies like cognitive behavioral therapy and non-opioid pharmacologic treatments. The CDC's guidelines on prescribing emphasize careful assessment of pain management strategies and avoiding dose escalation in cases of suspected OI. Question 3. Scenario-based question. Ethical dilemma in pain management. Mrs. Thompson, 76-year-old woman with tidroman and pancreatic cancer, is receiving hospice care. Her physician has prescribed high-dose opioids for severe pain, but her son expresses concern about addiction and requests that the dose be reduced. Mrs. Thompson, however, is in distress and requests stronger pain relief. What is the most appropriate response by the pain management nurse? A. Explain to the son that addiction is not primary concern in end-of-life care and ensure that Mrs. Thompson's pain is adequately managed according to palliative care guidelines. B. Reduce the opioid dose to address the son's concerns even if it results in inadequate pain control. C. Advise Mrs. Thompson to endure the pain and try non-pharmacologic interventions instead of opioids. D. Call the physician to discontinue opioid therapy altogether. Switch to over-the-counter analgesics. Answer A. Explain to the son that addiction is not a primary concern in end-of-life care and ensure that Mrs. Thompson's pain is adequately managed according to palliative care guidelines. Explanation: in palliative and hospice care, the primary goal is comfort and quality of life. Concerns about addiction are generally not relevant in end-of-life pain management, as untreated pain can significantly reduce a patient's well-being. The WHO Pain Ladder and Guide from organizations like the American Academy of Hospice and Palliative Medicine emphasize that opioid therapy should be optimized to relieve distress in terminal patients. The nurse's role includes educating family members about the difference between addiction and appropriate pain control, ensuring the patient's autonomy in pain management, and advocating for evidence-based practices in palliative care. Reducing or discontinuing opioids without justification could result in unnecessary suffering, violating the ethical principle of beneficence. Question 4. Pharmacologic management of pain. A 72-year-old patient with osteoarthritis has been taking NSAIDs for chronic pain management. Due to increasing gastrointestinal side effects, the physician decides to switch the patient to acetaminophen. However, the patient also has a history of liver disease. What would be the most appropriate approach to managing this patient's pain while minimizing risks? A. Continue NSAIDs, but add proton pump inhibitor, PPI, to protect the stomach. B. Switch to acetaminophen, but limit the daily dose to 2 grams or less. C. Prescribe low-dose opioids such as hydrocodone as safer alternative. D. Recommend discontinuation of all analgesics and focus on non-pharmacologic pain management only. Answer. B. Switch to acetaminophen but limit the daily dose to 2 grams or less. Explanation. NSAIDs increase the risk of gastrointestinal bleeding, especially in older adults, while PPIs can reduce risks. Option A. NSAIDs still pose cardiovascular and renal risks. Acetaminophen is a safer alternative, but must be used cautiously in patients with liver disease. The maximum recommended daily dose in these patients is 2 grams. Option B. Opioids. Option C should not be the first-line treatment for chronic osteoarthritis pain due to risks of dependence, constipation, and sedation. Non-pharmacologic approaches. Option D are beneficial but may not fully replace analgesic therapy. Guideline reference. The American Geriatric Society AGS guidelines for pain management recommend acetaminophen as a first-line agent for osteoarthritis in older adults but with adjustments for liver disease. Question 5. Ethical and legal considerations in pain management. Scenario-based question. Dr. Carter, a pain management specialist, is treating a 45-year-old patient with chronic lower back pain due to a herniated disc. The patient has been on long-term opioid therapy, but Dr. Carter notices signs of opioid misuse, including requesting early refills, escalating doses without approval, and obtaining prescriptions from providers. When Dr. Carter confronts the patient, they become defensive and insist they need the medication to function. What is the most ethical and legally appropriate action Dr. Carter should take? A. Immediately discontinue the opioids and dismiss the patient from the practice. B. Conduct a thorough assessment. Consider a prescription drug monitoring program (PDMP). Check and discuss alternative pain management options. C. Increase the opioid dose to prevent withdrawal symptoms and ensure continued pain relief. D. Report the patient to law enforcement for suspected drug-seeking behavior. Answer. B. Conduct a thorough assessment, consider a check, and discuss alternative pain management options. Explanation. Abrupt discontinuation of opioids. Option A may lead to withdrawal symptoms and is not considered ethical without a tapering plan. A prescription drug monitoring program (PDMP). Check. Option B helps identify opioid misuse patterns. A multidisciplinary approach, including non-opioid analgesics. Behavioral interventions should be considered. Increasing the opioid dose. Option C without reassessment worsens dependence and contradicts evidence-based pain management practices. Reporting a patient to law enforcement. Option D is inappropriate unless there is clear evidence of illegal activity. Guideline reference. CDC guidelines for prescribing opioids 2022 recommend check PDMPs, reassessing patients regularly, exploring multimodal pain management before continuing opioid therapy. Question 6. Neuropathic pain and adjuvant analgesics. A patient diagnosed with diabetic peripheral neuropathy reports severe burning pain in their feet that worsens at night. The patient has tried acetaminophen and NSAIDs without relief. The provider is considering adjuvant analgesics. Which of the following would be the best initial treatment for this patient's neuropathic pain? Amitriptyline, tricyclic antidepressant. B. Tramadol, weak opioid agonist. C. Ibuprofen, non-steroidal anti-inflammatory drug. D. Hydrocodone acetaminophen, combination opioid analgesic. Answer A. Amitriptyline, a tricyclic antidepressant. Explanation. Neuropathic pain does not typically respond well to NSAIDs. Option C, or simple analgesics. Tricyclic antidepressants TCAS like amitriptyline, option A, or serotonin norepinephrine reuptake inhibitors NRIS like duloxetine are first-line treatments for neuropathic pain. Tramadol, option B, may be used in refractory cases but has risks of dependence. Opioids, option D, should only be used as a last resort due to potential for tolerance and addiction. Guideline reference: the American Diabetes Association, ADA, and International Association for the Study of Pain (IASP) recommend TCAS and NRIS as first-line treatments for neuropathic pain. Question 7. Pediatric pain management. A 6-year-old child is recovering from a tonsillectomy and experiencing moderate pain. The physician considers prescribing an opioid but is concerned about safety. Which of the following statements is correct regarding opioid use in pediatric pain management? A. Codeine is a safe option for children as it has a mild opioid effect. B. Morphine is preferred over codeine due to its predictable metabolism. C. NSAIDs should never be used in children for post-surgical pain. D. Opioids are the first-line treatment for all post-operative pediatric pain. Answer: B. Morphine is preferred over codeine due to its predictable metabolism. Explanation: codeine, option A, is not recommended in children due to genetic variability in metabolism, which can cause fatal respiratory depression. Morphine, option B, is a safer alternative as it has a predictable pharmacokinetic profile in children. NSAIDs, option C, like ibuprofen, can be used safely in children for moderate pain. Opioids, option D, should not be first line. Multimodal analgesia, NSAIDs, acetaminophen, should be attempted first. Guideline reference: FDA and American Academy of Pediatrics recommend avoiding codeine in children due to the risk of ultra-rapid metabolism leading to toxicity. Question 8. Cancer pain management. A 58-year-old woman with STID-Roman arrest cancer is experiencing breakthrough pain despite being on a long-acting opioid regimen. What is the best strategy to manage her breakthrough pain? A. Increase the dose of her long-acting opioid. B. Prescribe a short-acting opioid for breakthrough pain. C. Switch to a non-opioid medication like acetaminophen. D. Discontinue opioid therapy due to concerns about tolerance. Answer: B. Prescribe a short-acting opioid for breakthrough pain. Explanation: breakthrough pain is a sudden flare-up of pain despite baseline analgesia. Short-acting opioids, option B, like fentanyl, lozenges, or oxycodone are the preferred treatment. Increasing the baseline dose, option A, may lead to oversedation. Non-opioids, option C, are insufficient for severe breakthrough cancer pain. Discontinuation, option D, is inappropriate. A tolerance does not equate to addiction. Guideline reference: WHO cancer pain guidelines advocate for a combination of long-acting opioids with short-acting opioids for breakthrough pain. Question 9. Chronic pain and non-pharmacologic approaches. A 67-year-old retired construction worker presents with chronic lower back pain due to degenerative disc disease. He has been taking ibuprofen and acetaminophen with moderate relief but still struggles with daily activities. The patient is hesitant about stronger medications and asks about non-pharmacologic options. Which of the following would be the most evidence-based recommendation? A. Refer to a neurosurgeon for surgical evaluation. B. Recommend long-term bed rest to minimize pain. C. Encourage physical therapy and cognitive behavioral therapy. D. Initiate long-term opioid therapy at a low dose. Answer: C. Encourage physical therapy and cognitive behavioral therapy. Explanation: physical therapy (PT) and cognitive behavioral therapy (CBT) are first-line treatments for chronic low back pain. Surgery, option A, is only considered for refractory cases with neurological deficits. Bed rest, option B, is discouraged as it leads to deconditioning. Long-term opioid therapy, option D, is not recommended for chronic non-pain due to the risk of dependence. Guideline reference: American College of Physicians recommends EBT and exercise for chronic low back pain. Question 10. Pain management in renal impairment. A 75-year-old patient with end-stage renal disease (SID) is experiencing severe osteoarthritis pain. Which of the following analgesics would be most appropriate for this patient? A. Ibuprofen. B. Morphine. C. Acetaminophen. D. Naproxen. Answer: C. Acetaminophen. Explanation: NSAIDs options and D are contraindicated in renal impairment due to nephrotic cystoscopy. Morphine, option B, is not preferred because its active metabolites accumulate in renal failure, leading to toxicity. Acetaminophen, option C, is the safest choice for mild to moderate pain. Guideline reference: Kidney disease, improving global outcomes. KDIGO guidelines recommend acetaminophen as the first-line analgesic in renal failure. Question 11. Opioid rotation. A cancer patient on high-dose morphine, 90 mg day, is experiencing severe sedation and poor pain control. The provider decides to switch to an equivalent dose of fentanyl. What is the best strategy for opioid rotation in this case? A. Calculate the equivalent dose and reduce by 2,550% to account for incomplete cross-tolerance. B. Use the exact equivalent dose without adjustments. C. Start fentanyl at a much lower dose and taper morphine over 4 weeks. D. Discontinue morphine abruptly and initiate fentanyl at full potency. Answer A. Calculate the equivalent dose and reduce by 2,550% to account for incomplete cross-tolerance. Explanation: when switching opioids, cross-tolerance is incomplete, so the new opioid dose should be reduced by 2,550%. Exact equivalent conversion. Option B. Risks overdose. Starting too low. Option C. May lead to undertreatment. Abrupt discontinuation. Option D. Withdrawal symptoms. Guideline reference: American Pain Society (APS) recommends dose reduction during opioid rotation to prevent overdose. Question 12. Managing opioid-induced constipation. A patient on chronic opioid therapy for cancer pain complains of severe constipation despite using fiber supplements. What is the most appropriate next step? A. Increase fiber and water intake. B. Initiate a stimulant laxative like Senna or Bisacidil. C. Discontinue the opioid. D. Add an opioid antagonist like naloxone. Answer B. Initiate a stimulant laxative like Senna or Bisacidil. Explanation: fiber, option A, is insufficient alone. The opioids slow peristalsis, making bulk-forming agents ineffective. Stimulant laxatives, option B, are recommended for opioid-induced constipation. Stopping the opioid, option C, is not always feasible. Naloxone, option D, is not effective orally for constipation. Guideline reference: American Gastroenterological Association (AGA) recommends stimulant laxatives for opioid-induced constipation. Question 13. Pain management in palliative care. A hospice patient with metastatic pancreatic cancer has severe opioid refractory pain. What is the best next step in managing this patient's pain? A. Increase the opioid dose until pain is relieved. B. Consider palliative sedation. C. Switch to different opioid. D. Encourage non-pharmacologic pain management alone. Answer B. Consider palliative sedation. Explanation: palliative sedation is used for intractable pain when opioids are ineffective. Increasing the opioid dose, option A, may not help if tolerance develops. Switching opioids, option C, may work but is not always successful. Non-pharmacologic options, option D, are insufficient alone for severe pain. Guideline reference: American Academy of Hospice and Palliative Medicine (OPAMS), palliative sedation in refractory pain. Question 14. Opioid tapering strategy. A patient has been on chronic opioid therapy for 5 years and is now ready to taper off. What is the best tapering strategy? A. Reduce the dose by 10% every 1-2 weeks. B. Discontinue immediately and manage withdrawal symptoms. C. Switch to methadone for an easier transition. D. Reduce the dose by 50% each day. Answer A. Reduce the dose by 10% every 1-2 weeks. Explanation: a slow taper, option A, is recommended to minimize withdrawal symptoms. Immediate discontinuation, option B, leads to severe withdrawal. Methadone, option C, is used for opioid use disorder, not routine tapering. Reducing by 50% per day, option D, is too rapid. Guideline reference: CDC opioid prescribing guidelines recommend gradual taper opioids. Question 15. Postoperative pain management. A 50-year-old man undergoing a total knee replacement asks about the best pain management strategy. What is the most appropriate multimodal approach? A. Opioids alone. B. NSAIDs and acetaminophen with opioids as needed. C. Epidural anesthesia only. D. No analgesia to avoid opioid use. Answer B. NSAIDs and acetaminophen with opioids as needed. Explanation: multimodal analgesia, option B, reduces opioid dependence and improves pain control. Opioids alone, option A, are not ideal due to side effects. Epidural anesthesia, option C, is useful but not sufficient alone. Avoiding analgesia, option D, leads to unnecessary suffering. Guideline reference: American Society of Anesthesiologists (ASAP) recommends multimodal pain management for surgery. Question 16. Neuropathic pain treatment. A 55-year-old woman with diabetic peripheral neuropathy complains of burning pain in her feet, especially at night. She has tried acetaminophen and NSAIDs with no relief. Which of the following is the best next step in her pain management? A. Gabapentin. B. Morphine. C. Corticosteroids. D. Acetaminophen. Answer A. Gabapentin. Explanation. Gabapentin is a first-line treatment for neuropathic pain along with pregabalin, NRIS, and TCAS. Opioids, option B, are not first-line for neuropathic pain. Corticosteroids, option C, are not indicated for chronic neuropathy. Acetaminophen, option D, has no effect on nerve pain. Guideline reference. American Academy of Neurology on recommends gabapentinoids for diabetic neuropathy. Question 17. Cancer pain management. A 68-year-old patient with metastatic lung cancer has severe bone pain that is not well controlled with opioids. What is the best additional therapy for pain control? A. Radiation therapy. B. Acetaminophen. C. Long-acting benzodiazepines. D. Tricyclic antidepressants. Answer A. Radiation therapy. Explanation. Radiation therapy is effective for cancer-related bone pain. Acetaminophen, option B, is insufficient. Benzodiazepines, option C, do not relieve bone pain. TCAS, option D, are for neuropathic pain, not bone pain. Guideline reference. American Society of Clinical Oncology, ESCO, recommends radiation for bone metastasis. Question 18. Opioid use disorder in chronic pain. A patient with chronic back pain has been on long-term opioid therapy but shows signs of opioid use disorder including early refills and dose escalation. What is the best management approach? A. Transition to buprenorphine and naloxone. B. Continue opioid therapy at the same dose. C. Switch to NSAIDs only. D. Stop all pain medications abruptly. Answer A. Transition to buprenorphine and naloxone. Explanation. Buprenorphine and naloxone is appropriate for patients without and chronic pain. Continuing opioids, option B, without intervention worsens addiction. NSAIDs alone, option C, may not provide adequate pain relief. Abrupt withdrawal, option D, leads to withdrawal symptoms and relapse. Guideline reference. CDC and ASOM guidelines recommend buprenorphine for opioid-dependent patients. Question 19. Post-herpetic neuralgia. An 80-year-old woman presents with persistent burning pain in edematome distribution following a shingles outbreak 3 months ago. Which of the following is the most appropriate first-line treatment? A. Topical lidocaine patches. B. Acetaminophen. C. Prednisone. D. Codeine. Answer A. Topical lidocaine patches. Explanation. Lidocaine patches are first line for post-herpetic neuralgia PHN. Acetaminophen, option B, is ineffective. Prednisone, option C, is only useful during acute shingles, not PHN. Opioids, option D, are not first line. Guideline reference. Neurology guidelines recommend topical lidocaine or gabapentinoids for PHN. Question 20. Safe opioid prescribing. A physician is considering prescribing opioids for a patient with chronic pain. What is the most important step before initiating opioid therapy? A. Perform a risk assessment for opioid misuse. B. Prescribe the maximum allowable dose. C. Avoid discussing potential side effects. D. Start with a long-acting opioid. Answer A. Perform a risk assessment for opioid misuse. Explanation. Risk assessment, option A, identifies patients at higher risk of opioid misuse. Starting at the max dose, option B, is unsafe. Informed consent, option C, is crucial in opioid therapy. Short-acting opioids are preferred initially over long-acting formulations, option D. Guideline reference. CDC guidelines recommend risk assessment before prescribing opioids. Question 21. Ketamine for pain management. A trauma patient with severe pain and opioid tolerance is not responding well to standard opioid doses. The physician considers romnitamine as an adjunct. What is the primary advantage of ketamine in pain management? A. It reduces opioid tolerance and hyperalgesia. B. It has no side effects. C. It is safer than NSAIDs in all patients. D. It is more potent than morphine. Answer A. It reduces opioid tolerance and hyperalgesia. Explanation. Ketamine is an NMDA receptor antagonist that reduces opioid tolerance and hyperalgesia. It does have side effects, option B, including hallucinations. NSAIDs, option C, are still preferred in some cases. It is not more potent than morphine, option D, in all cases. Guideline reference. Ketamine is used as an adjunct for opioid-resistant pain per APS guidelines. Question 22. Pain management in pregnancy. A pregnant woman, third trimester, presents with severe joint pain due to rheumatoid arthritis. What is the safest analgesic option? A. Acetaminophen. B. NSAIDs. C. Oxycodone. D. Methotrexate. Correct answer A. Acetaminophen. Explanation. Acetaminophen is the preferred analgesic in pregnancy. NSAIDs option B are contraindicated in the third trimester due to ductus arteriosus closure. Opioids option C carry risks of neonatal withdrawal. Methotrexate option D is teratogenic. Guideline reference. ACOG recommends acetaminophen as first-line pain relief in pregnancy. Question 23. Opioid overdose management. A patient presents to the ER with respiratory depression and pinpoint pupils after suspected opioid overdose. What is the most appropriate initial treatment? A. Naloxone. B. Activated charcoal. C. Flumazenil. D. Methadone. Answer A. Naloxone. Explanation. Naloxone option A is the antidote for opioid overdose. Activated charcoal option B is not useful for opioid toxicity. Flumazenil option C is for benzodiazepine overdose. Methadone option D is used for opioid dependence, not overdose. Guideline reference. CDC and WHO recommend naloxone for opioid overdose reversal. Question 24. Chronic pain and psychological factors. A 50-year-old woman with fibromyalgia reports widespread pain, fatigue, and depression. She has tried NSAIDs and acetaminophen without relief. Which of the following is the most appropriate next step in her treatment? A. Amitriptyline. B. Oxycodone. C. Prednisone. D. Acetaminophen. Answer A. Amitriptyline. Explanation. Amitriptyline, a tricyclic antidepressant, is effective for fibromyalgia. Opioids option B are not recommended. Steroids option C are not indicated. Acetaminophen option D has limited efficacy in fibromyalgia. Guideline reference. ACA guidelines recommend TCAS and NRIS for fibromyalgia. Question 25. Opioid tapering. A patient on chronic opioid therapy wants to taper off opioids due to side effects. What is the best approach to opioid tapering? A. Reduce the dose gradually over weeks to months. B. Stop opioids abruptly. C. Substitute with benzodiazepines. D. Increase the dose before tapering. Answer A. Reduce the dose gradually over weeks to months. Explanation. Gradual tapering prevents withdrawal symptoms. Abrupt cessation option B leads to withdrawal. Benzodiazepines option C are not a substitute. Increasing the dose option D before tapering is not recommended. Guideline reference. CDC opioid guidelines recommend slow tapering to minimize withdrawal. Question 26. NSAID-related GI toxicity. A 67-year-old patient with osteoarthritis has been on naproxen for 3 months and now reports abdominal pain and dark stools. What is the most appropriate next step? A. Discontinue NSAID and test for GI bleeding. B. Increase the NSAID dose. C. Add a proton pump inhibitor PPI. D. Switch to aspirin. Answer A. Discontinue NSAID and test for GI bleeding. Explanation. NSAIDs increase GI bleeding risk, especially in older patients. Increasing the dose option B worsens GI risk. PPES option C can help, but first evaluate for bleeding. And aspirin option D increases bleeding risk. Guideline reference. American College of Gastroenterology recommends stopping NSAIDs in suspected GI bleeding. Question 27. Pain management in end-of-life care. A hospice patient with advanced cancer has intractable pain despite high-dose opioids. What is the best next step? A. Consider palliative sedation. B. Increase the opioid dose indefinitely. C. Stop all medications. D. Encourage physical therapy. Answer A. Consider palliative sedation. Explanation. Palliative sedation is appropriate for refractory pain at end of life. Increasing opioids indefinitely. Option B may not help. Stopping medications. Option C is unethical. Physical therapy. Option D is not helpful in terminal illness. Guideline reference. WHO and palliative care guidelines recommend palliative sedation for intractable suffering. Question 20. Pain in sickle cell disease. A 25-year-old patient with sickle cell disease presents with a pain crisis. What is the most appropriate initial treatment? Roman opioid and Romanuids. B. NSAIDs alone. C. Oxygen therapy only. D. Blood transfusion immediately. Answer. Roman opioid and Romanuids. Explanation. Opioids and Romanuids are first line for sickle cell pain crises. NSAIDs alone, option B, are not sufficient. Oxygen option C is used only if hypoxic. Transfusion option D is reserved for severe complications. Guideline reference. American Society of Hematology recommends opioids and fluids for pain crises. Question 29. Neuromodulation for chronic pain. A patient with chronic refractory back pain has failed opioids, physical therapy, and nerve blocks. What is the best next step? A. Spinal cord stimulation. B. Long-term opioids. C. NSAIDs. D. Corticosteroid injections. Answer A. Spinal cord stimulation. Explanation. Spinal cord stimulators are used for chronic refractory pain. Long-term opioids option B are not first line. NSAIDs option C and steroid injections option D have already failed. Guideline reference. Pain management guidelines recommend spinal cord stimulation for refractory pain. Question 30. Trigeminal neuralgia treatment. A 60-year-old patient has sudden severe electric shock-like pain on one side of the face. What is the first-line treatment? A. Carbamazepine. B. NSAIDs. C. Acetaminophen. D. Opioids. Answer A. Carbamazepine. Explanation. Carbamazepine is first line for trigeminal neuralgia. NSAIDs option B and acetaminophen option C are ineffective. Opioids option D are not recommended. Guideline reference. Neurology guidelines recommend carbamazepine for trigeminal neuralgia.